Welcome, everyone. Thank you for coming today. Today's Sight and Sound Bites webinar, our topic is otolaryngology, survivorship, providing coordinated care to head and neck cancer patients. So as you might know, the Eye and Ear Foundation hosts these Sight and Sound Bites webinars every month, and we feature different topics related to vision loss, hearing loss, head and neck cancer, sinus, allergy, balance disorders, and conditions of the voice. My name is Carrie Fogel. I'm the Director of Development and Foundation Relations at the Eye and Ear Foundation, and I'll be the moderator of today's webinar. Thank you for coming. Just a few quick housekeeping items before we get started. We won't be using the chat function in today's webinar, but instead we ask that you submit your questions to the Q&A box at the bottom of your Zoom screen, and you can do so at any point during the conversation. And following the presentation of our speakers, I'll be leading a Q&A portion with our panelists. We ask that you keep the questions general and not ask about any personal or specific medical conditions that might not be relevant to our whole audience. However, if you do have any questions that are more personal in nature, or if we don't have time to answer a question that you submit, we will send the questions directly to our speakers, and the answers can be sent directly to you via email. There will also be a video of today's discussion available on the Eye and Ear Foundation website. So without further delay, I'd like to welcome our speakers, Dr. Jonas Johnson and Dr. Marcy Nielsen. They are the founders and directors of the UPMC Head and Neck Cancer Survivorship Clinic. Dr. Jonas Johnson has committed his life's work to the treatment of patients with diseases of the head and neck and in the environment of education and inquiry. His current appointment is as Distinguished Service Professor and Chairman of the Department of Otolaryngology at the University of Pittsburgh School of Medicine. Dr. Johnson holds the Eugene N. Myers Chair in Otolaryngology, and most recently his work has focused on survivorship care for head and neck cancer survivors and the avoidance of low-value interventions. In addition to his clinical practice, he has established a scholarly record of peer review publications, extensive mentorship experience, and has a long history of interdisciplinary collaboration. And our second speaker today is Dr. Marcy Nielsen. Dr. Nielsen is an assistant professor in acute and tertiary care at the University of Pittsburgh School of Nursing. Dr. Nielsen's research focuses on identification, treatment, and development of interventions focused on the management of symptoms and treatment-related side effects in head and neck cancer. Dr. Nielsen also holds a secondary appointment, in the University of Pittsburgh School of Medicine's Department of Otolaryngology. So I'd like to welcome them both today, and I will turn it over to you to begin the presentation. Thank you.
So thank you very much, Carrie, and certainly we welcome the people online to participate in this webinar. So today what I wanted to do is introduce you to throat cancer. We call it head and neck cancer. Head and neck cancer is really cancer that develops in the throat, the mouth, the sinonasal tract, and then the back of the throat, which is, of course, the larynx and the pharynx. We call out special attention to this green area, which is called the oral pharynx. The reason is that the epidemiology of throat cancer has evolved in the last decade or two. And oral pharyngeal cancer is currently the cancer we see with the most prevalence. It's really become a bigger and bigger problem, not only in Pittsburgh and in the United States, but worldwide. So we'll go to the next slide. So when I think about cancer, I recognize that cells in your body, certainly the surface cells like the skin or the throat, are dividing. That is, they're having these mitoses constantly. And the reason is that your skin is replaced with new skin again and again. And the same is true of the lining of your mouth and your throat. It's replaced regularly. And so environmental cancer-causing agents seem to play a big role in the development of throat cancer. So historically, we thought the big bad boy was tobacco. And certainly when I was training, that's what we were taught. Smoking causes throat cancer. And it's only in more recent years that we've come to appreciate the reality that viruses can cause throat cancer. For instance, the most common cancer in Asia is in the nasopharynx, which is behind your nose. And that's caused by a thing called the Epstein-Barr virus. There's a skin cancer that's caused by a virus. It's called Merkel cell carcinoma. And then what we'll talk today a little bit about is this oral pharyngeal cancer caused by human papilloma virus, which we refer to as HPV. So let's go to the next slide. So this is very important. So on your left is sort of our conceptualization of tobacco causing cancer. And what's interesting is that tobacco does cause probably something like 50 different mutations in your cells. So it's not all one mutation. And of course, that makes it harder to target these mutations or to treat them. On the right is a cartoon showing what a human papilloma virus looks like under huge magnification. And isn't it interesting that HPV virus causes different mutations? So in truth, these two cancers look very similar under a microscope. They're both called squamous cell carcinoma, but the causes are very different, and the mutations that lead to the cancer are also very different. Next slide. So this graph is intended to remind me to say that this throat cancer caused by HPV has been going up and up and up. Now, it was only really linked to throat cancer about 20 years ago. They linked HPV to pelvic cancer in women back in the 1980s. But it took another 20 years to realize that this exact same virus is causing cancer in our throat. And where this cancer selectively develops is in the oral pharynx, which I showed you in one of the first slides. It's the back of the tongue, which is not the front of the tongue. It's the back of the tongue. We call it the tongue base. You cannot see, and it's the tonsils. That's where these cancers develop. And today, as I pointed out, throat cancer due to HPV is more prevalent than uterine cervical cancer, and it's the most common cancer that we see. Next slide. So can it be treated? Well, so there's sort of good news and bad news. HPV-related cancer is pretty easy to treat. And what I mean by that, it's easy to cure. The cure rate is over 90%. So that's wonderful. The problem is that it takes sometimes surgery or a radiation alone, but those modalities are used for very small cancers. And if the cancer is bigger or associated with lumps in the neck, which we call metastases or lymph nodes, then very commonly people are treated with surgery and a radiation. And sometimes they're treated with a radiation and chemotherapy. And as you're going to hear in a minute, people with more advanced cancers, which can still be cured, they can be cured, but they have required surgery, radiation therapy, and chemotherapy. So using these modalities has been exceedingly effective, for which we're so grateful, because we like cured people. But there's late and long-term effects. So let me have Marcy Nielsen walk you through this.
Sorry, my computer's transitioning. So late and long-term effects are things that can either happen during radiation and continue, or they can happen after months to years after radiation or treatment's done, not just radiation, but treatment. And so this could be something that may be difficult to understand is related to your treatment because there is this potential time gap. And so one example would be, thyroid dysfunction. So sometimes people's thyroid slow down, and that may not happen till 5 or 6 years after treatment, specifically radiation. So sometimes it's hard for people to kind of tie them back to your treatment, but these are just several that we know are related to treatment, and that could be chemo, surgery, or radiation. So many of you, I did take a look at the attendee list, and thank you for coming. And I do recognize some names, so I think there are people who are familiar and who have attended. But we do run a multidisciplinary survivorship clinic through UPMC at Ioneer. It started in 2016. And we meet every Thursday. And so the group that we've combined we brought together is an audiology assistant. So that's Lizzie, and she'll screen your hearing, fix hearing aids. We have 2 nurses. We have a speech language pathologist or a surgeon, and/or on a rare occasion, we do have an advanced practice provider who will step in, speech language pathologist, a physical therapist, a dentist, and a dietitian was our most recent addition. And this all occurs in one visit, in one clinic, in one copay. And the reason for this grouping is because we know that these late and long-term effects and these symptoms that patients have really cross disciplines. And so to make the best plan, a lot of times we have to leverage each of these groups to kind of come up with a plan to move forward. And so in this came from a book that was published in 2005, really saying that patients who complete treatment sometimes feel that transitioning to that more sustained survivorship period, or a period when you're not having as close contact with your providers, can be really stressful, and it can be a time that people fall through or receive really fragmented care. And so based off this report, American Society of Clinical Oncologists and other groups recommended 4 different things to do to qualify as high quality care. So prevention, these are prevention of additional cancers. So if somebody comes and they're smoking, we recommend smoking cessation, limited alcohol use, skin screening for sun cancer. Surveillance is what has always been happening. Patients come in very frequently in the beginning to check to see if their cancer has come back or if a second cancer has appeared. Management is where the focus really has amplified. This is management of symptoms and late and long-term effects. And sometimes that's done by the provider. Sometimes it's coordination of care with additional providers, including the primary care doctor. So if you've been through survivorship, you know that we have a tablet, and many of you may not like it, but I promise that this tablet does help us. So these tablet has questions, which what we call our patient-reported outcomes. And the reason we give these are, 1, for patient engagement. We want to know what you are experiencing. 2, it also helps us plan your visit. And so we ask questions about health literacy. This is really kind of helping us expand how we target and provide information, quality of life, symptoms of anxiety and depression, which we know are very prevalent, swallowing difficulty or dysphagia, neck disability, which is stiffness or tightness in your neck that causes pain, and sleep trouble or insomnia. And so out of all of these questions that we ask, we do use the University of Washington quality of life a lot because it lets patients pick what's most important to them, which then helps us align our care. So what are the most common treatment-related effects that our survivors report? And so swallowing, I'm sure none of you are surprised, but swallowing or dysphagia is the top. Saliva, so that's xerostomia or dry mouth, is second, and pain, which was surprising for me initially, has ranked 3rd since the beginning of our survivorship clinic. And then the rest have stayed fairly similar in terms of percentages. So also looking at speech, activity, chewing kind of goes back and forth in that top 5. But these have been fairly steady, and we've seen about 3,500 patients. Some of those patients we see multiple times, so it equates to about 1,500 unique patients. So dysphagia, I mentioned quickly, is one of our top, and about, now you'll say, Marcy, that's at 50%. This says 73%. So 50% of patients report it as one of a significant issue that impacts them. But when we look at their questions related to how well they swallow, they score high enough that they are worried about dysphagia. Either self-reported dysphagia or then follow-up exams could be warranted. So about 74% of our patients report symptoms that really concern us for dysphagia. And so that's a huge portion, obviously, of our patients. And I don't think it's surprising, and it's been the symptom that most people have focused on. One of the things I do want to point out, and I think is important, because as we talked about those late effects, if you see this little purple line at the bottom, now when you first look at it, it's like, oh, wait a minute, this is kind of looking like things are getting worse, but this is actually, things are getting better. Patients are reporting less symptoms until about this 6-year mark. And then patients start to statistically report higher symptom burden. And so this is what we talk about, one of those late effects. It technically could be either a long-term effect, because you could have trouble with it from treatment, or you could have new symptoms that start around this time. And the reason is, we know that your anatomy changes, and we know that radiation kind of continues, and that it changes your skin, it changes your musculature, and you also age. So which is it? It's probably a combination of both of them, aging and treatment. And patients at 6 years start to report more symptoms. And so then you may not be seeing your doctor as often. And so it's important, if you develop these new symptoms, to really go back and talk to most likely your otolaryngologist, your ENT doctor, to reevaluate your swallowing, see if there's anything that we can do to prevent things like aspiration pneumonia. Now, pain. So most of this will talk about pain, and it's not just, it's a bunch of different types of pain. But if you go back to this slide, you'll remember that I said it's top 3. So I think it's fairly surprising that it gets to about 30% of our patients report some degree of pain that impacts their life or their daily activities. And so we wanted to try to do a better job of capturing this chronic pain. And so we identified very early on in the survivorship clinic, we saw this as something that was coming up and troublesome. And so we wanted to see what's our prevalence, but also what are the risk factors for developing this chronic pain. Technically, if you want to get technical, it's technically just pain, because chronic pain has to be measured more than once. But we did identify that 175 patients on a median of 6.6 years out, so getting into that more permanent phase of survivorship, that 45.1% of them reported pain, and 11% reported severe pain. And so when we adjust for certain things, because in statistics, we know that things are associated, and so we kind of have to control for them to see what pain's associated with. And we know that if you get a trimodality therapy, so that would be, for example, surgery first, followed by chemo radiation, you're more likely to have pain. And if you have pain, it's associated with higher levels of depression, anxiety, less recreation, so less ability to participate in recreation, and overall more lower quality of life. And so the problem with this is what is pain? So if you say to me, Marcy, I have pain, it could be anywhere. It could be your mouth, it could be your neck, it could be your tongue, it could be when you swallow. So while this is interesting and really important to highlight that our patients have this continuing issue, it doesn't give us a whole lot of information about the type of pain or location of pain. And so to have an intervention or some kind of modifier is a little bit difficult. So we've looked more at different types of pain. So neck disability, I'm sure if we've met, I've talked about this more than once. So neck disability is really cervical. We know that cervical and upper limb, so your shoulders, can have trouble after surgical resection and reconstruction. It's anticipated. However, there really is a limited literature looking at the physical impairments of non-surgical management. So when I talk about non-surgical management, primarily I'm talking about radiation, sometimes with the addition of chemo. So prior studies have shown this ranges from 30 to 80%. That's a huge range. And that could be because of we do use multiple modalities to treat patients. Patients have different sites. So that kind of always makes research in this area a little bit more difficult. So we wanted to see the prevalence and predictors. So what's associated with neck disability following head and neck cancer treatment? And is it associated with quality of life? So yes, 55% of our patients, again, half of our patients have some form of neck disability. Again, neck disability is pain in your neck that really limits your function on a daily basis. So this could be driving, this could be reading, headaches. And when we break it down, most of our patients do have only mild to moderate pain. So they're not at the severe to complete phase, but even that mild to moderate pain, we need to recognize is important, and we'll see why. But 50% of our patients do report mild to moderate pain. So as you can imagine, when we look at predictors of neck disability, we see that when you compare to surgery alone, this non-surgical, this is the p-value, which just means it's significant. Patients who have non-operative treatment are about 2.2, almost 3%, 3 times likelier to have neck disability than patients who have surgery alone. And this goes up when you're looking to about 4 times when you're looking at surgery and adjuvant treatment or surgery and radiation following compared to surgery alone. Now, the interesting note is that when you look at non-operative treatment versus surgery and additional treatment, it's not really statistically significant. It goes up a little bit. So this being said, it's important to note, and I think surprises patients sometimes, if we haven't discussed it pre-treatment, is that radiation, while not maybe seen as intrusive as surgery, because you're not cutting into the skin, it really does impact your skin and your musculature. And so this has been an area that really I've focused on in terms of my research, because I think the way we address it right now is physical therapy, but we don't know a lot about it. And can we know more so we can, again, tailor? We do know that patients who have neck disability do have lower physical and psychosocial quality of life. And we do, again, know that if the more treatment you have, the more likely you are to have lower kind of quality of life when you compare it to surgery alone. And so is this neck disability, does this just happen in isolation? Do you just have trouble with your neck and that's it? Or do things, as we like to say, as I like to say, or nurses like to say, do things cluster together? So if I have neck disability, am I more likely to have any other symptoms like dysphagia or swallowing trouble or insomnia? And so we know that head and neck cancer patients can develop muscular atrophy, which is, thinning of the skin and the musculature, weakness. They can develop contractures. So we sometimes call that forward head posture, which is maybe a term which kind of is, if you look at to the side, your head is a little bit further down and it's harder to kind of keep it straight up. And so the main contributors to neck disability and dysphagia, poor posture, reduced range of motion, trismus, so not being able to open your mouth, and pain. So again, we wanted to do a better job of understanding this and understanding how these relate to each other. So this was one of our med students, and she looked at neck disability and dysphagia. And so the main point is really this graph. If you do not report neck disability, your symptoms of dysphagia are pretty low. You're swallowing good. You don't feel like food sticking. You don't feel like you're coughing. And as your neck disability increases, so does your trouble swallowing, at least when we kind of look at this correlation and compare it. And so when you get into this group of more moderate to complete neck disability, we do know that it's associated with swallowing symptoms that are high enough that we should be concerned for aspiration or aspiration pneumonia occurring. And so it really gives us an idea of that this doesn't happen again in isolation. It's likely that these symptoms kind of co-occur with other symptoms. Now, again, is it just pain, or does it actually kind of affect how you move and how you function? So one of the things I hear commonly, especially with people who have really more severe to complete neck disability, is that they can't really turn their head to look over their shoulder when they're driving, or can't really even turn to look at the mirror. But there's not a lot of data to show that neck disability and limited range of motion occur together. So some of you may have done this. We kind of strap these fancy little devices to patients as they were sitting. They called IMUs, and we have people rotate and do some flexion and extension and lateral bending, and we can see not just the degree of motion, but how fast you do it. And so when we looked at this, we did see that patients who have pain, some degree of pain, because this was a small study, it was only 30 patients. It was more of a feasibility to see if we could get patients to really trying to figure out where to put you guys so I can see some of these. But so we know that range of motion and flexion and extension were significantly lower in patients who have pain. And so we looked at this in two different pains. So higher range of motion, inflection, extension, which is this and this, and lateral bending. If you didn't have pain and you actually did this faster, again, turning side to side, if you didn't have pain. And then when we looked at neck disability, the results were also similar. So if you have more neck disability, you have less range of motion and you use less velocity. And the reason we looked at these kind of three different degrees, extension, flexion and extension, lateral rotation, and bending, is because these do relate to kind of activities that you commonly do. Turning your head would be looking at your mirrors, flexion and extension if you're looking up or you're trying to pick something up. So how do these impact? And they also use different muscles. And so we know that neck disability and pain can correlate to other symptoms. And we know that we see physical changes in terms of being able to have good range of motion and velocity, but we don't know a lot of things still. One, why if two of you in the audience are coming in, you have similar treatment and similar stage of cancer, similar histology, but one person in one room has really more severe neck disability and one has none. Why does that happen? If you've got the same dose of radiation and you have the same kind of field area, what's the difference? So we're looking at differences in omic variation. So we've looked at focusing more on what we call microRNA, which microRNA produce proteins. And there seems to be that there are microRNA that are elevated or changed in patients who have more neck disability. So could we target patients or do something preventatively to minimize some of this fibrosis and this neck disability that occurs? More objective measures of fibrosis. So if I've met you, I might have pinched your neck. I usually say this is not very scientific, but it is the way we measure, standard way we measure neck fibrosis is I pinch your neck and see if your skin moves or if I could push it. So is there a better way to really capture these changes to your musculature? So some ways are CT scans. We're working on a new study looking at ultrasound to look at some of the sternocleidomastoid muscle, which is your big muscle, but some of these also more thinner extensors and flexors in the neck. And that's fairly non-invasive, and it can help us start to build exercise programs that are more targeted towards the issues that patients experience. Longitudinal, how does this progress? There's a lot of this stuff is looking at just a snapshot of people at one point. So when does this occur? Does it occur early? Does it worsen? And so really to do that, we really need to follow patients over time. And fibrosis and co-occurring. So fibrosis is that stiffness in your skin and musculature. Does it change over time? Or does it stay the same? Does it interact with other things? I'll tell you that we have a paper that we're working on and looking at neck disability and pain in the neck, and we're also related to insomnia, trouble sleeping, which is not surprising, but hasn't been associated together. So all these symptoms, these things can really lead to hospitalizations in our survivors. And so what we looked at here was actually, does a visit to survivorship help keep you out of the hospital? So this was early on, pre-2020, but what we did see is that if you have a survivorship visit, then you're less likely to have a hospitalization over the next year. So hopefully this is because we are pairing you with people like physical therapists and speech language pathologists to minimize some of these symptoms. If they're identifying changes, they get us to you, you get you to us, or we get you to the appropriate physician early. And so we're continuing to look at this, and obviously the implication is it is good for you, it's good for us if we keep you out of the hospital appropriately. There's less co-pays for you, less risk of things that happen in the hospital, but we also really want to maintain your quality of life. So the other part of survivorship that is something that we've progressed towards recently. So most of this has always been in people who are post-treatment. That was the purpose of the clinic, but quickly we started seeing patients pre-treatment. So pre-treatment is a great time for us to educate you, pair you with people you might need help with during treatment. Again, speech language pathologists, nurses. We have a program which we'll talk about shortly where we get those patients to you, or those providers to you in radiation oncology, so you don't have to come into Oakland all the time, but they come to you. And the goal of this is really to do this very similar thing. Can we keep you out of the hospital? Can we identify changes in your symptoms early so that we can address them and keep you out? Now, how many patients are hospitalized? How many head and neck cancer patients in treatment are hospitalized each year? It varies a little bit, but you may not be. You may be surprised to know. I was a little bit surprised to know because everybody tells me that Canada's healthcare is fantastic, that patients in Canada and patients in the United States undergoing radiation are hospitalized at very similar rates, 25 to 36%, 25 to 32%. So hospital utilization just means ER visits and hospital admissions. And why? If you've gone through chemo and radiation, you know that it's hard. It is not easy. We try to give you all the things that could happen, but I think it's really hard to understand how it'll be without having that reference. And sometimes, they say it's the worst sunburn you've ever had. That's probably doesn't even describe it very well. And so we know that these symptoms, pain being one of them, really drive patients to the hospital. Pain, nausea, vomiting, failure to thrive, which is loss of weight. And so while we know CRT or chemo and radiation can really improve survival, it does come with a high symptom burden. And so what can we do to really address those symptoms during treatment? Enhanced care study. So this was my creation as a nurse. How can we help you stay out of the hospital? We give you a nurse to help identify your symptoms and help coordinate your care. So that's the goal. The aim of the study is to really know if a symptom assessment intervention can reduce hospitalization. So patients get a nurse navigator and a speech language pathologist. They meet with them biweekly. They do have to answer questions on the iPad. It's easy though. They go 0 to 10. And then these two individuals coordinate with your team. The medical oncology team, the radiation oncology team, we also have a weekly meeting with the groups. So that we have also, when we started this study, very quickly, the dietitian, it was like, I want to be involved, I want to help. And so we have it's not really how clinical trials are supposed to run. You have your plan, but that's part of coordinating. So the dietitian also is involved. Historically, if you look at our rate, we're at about 25 to 30% for hospitalizations, depending on when you look. So the goal was to decrease hospitalizations by 10%. So again, if you've ever met Deborah Pickford used to work in survivorship with me, but I could not think of anybody better suited to do this study as my nurse kind of interventionist than Debbie. So she is our nurse navigator. She works with the SLP and a dietitian. We do make patients, we do biweekly vital signs and symptoms assessments with the pain index and the MD Anderson symptom index, which just looks at 20 some questions that we know happen, like how's your pain, 0 to 10. How's your swallowing trouble? 0 to 10. Sleep, cognitive function, 0 to 10. And then she coordinates with the oncology team. So what have we seen so far? These pictures might be a little bit hard to see. This was at the beginning. The goal is to get 250 patients enrolled. We're at 174 right now. But essentially what this shows you is that during radiation, the top 7 symptoms patients complain about are appetite, dry mouth, fatigue, nausea, pain, swallowing, and that little tiny one, taste. I couldn't even see it. So then when we look at chemo and radiation together, or radiation and chemo, radiation and immunotherapy, it's pretty similar, but it's slightly different. Appetite, dry mouth, fatigue, mucus, pain, swallowing, taste. And so this is just showing us kind of the most prevalent symptoms. And you may say, why are there 7 and not 5 or 3? And when we looked at these together, really, after these symptoms kind of really intertwined, you can see how they kind of wiggle in and out, and one's higher, one's lower. And the other symptoms that we didn't list here really had a kind of a significant gap. We could just see the difference in the numbers. And so that's why we pointed these out. They kind of all clustered together very easily visually. And then the others were ranging more on the lower level, and there was just a distinct gap between them. Again, symptom burden. So while not statistically significant, chemo and radiation has more symptoms than radiation alone. I don't think it's surprising. If you think of the goal of chemo is really to amplify radiation to cure you, if you're amplifying it, then it's likely going to cause more symptom burden. So in the end, we can't see now if patients with chemo and radiation are more likely to be hospitalized than radiation, but those are some of the questions we'll be able to tease out and look at when we get to 250 patients. So how are we doing so far? So I just presented in Scotland, and what I'll say is that symptoms such as pain, baseline pain, so high or elevated baseline pain is associated with increased likelihood of ER visit to the ER, but also a hospital stay. And so pain at baseline is something that we, again, still have to be able to address, because if you have high pain at baseline and then you start radiation, it wouldn't be unlikely that your pain would increase, and that may lead to uncontrolled pain and hospitalization. Nausea and vomiting were one of the other significant predictors related to hospitalization. And failure to thrive was kind of up in the top 3. Failure to thrive means, you're losing weight, you're having other symptoms that go along with it and may need a feeding tube placement. So the results of this are not quite there, but so stay tuned. Current hospitalization rates of enrolled patients are 16.8%. So not quite 10%, but pretty close. And so even if statistically I'm not significant, if it's not significant, I view almost a 10%, 9% decrease as significant for patients and for providers. And so really, is this a new potential model of care? Could we use this to enhance the value of care we provide to the patients, to the community, and to our organization? That really will then, if we can provide benefit to our organization, which on the baseline is just saving them money, can we provide more services to you, more nurses? Can we pay nurses to do this? Can we pay speech language pathologists to do this? Because we can show that we save both for the patient and the group. So hopefully, there may be other iterations of this in the future. One question has always come up is, can we do an intervention where we target the patient, but we also target the caregiver? So caregivers go through treatment with patients. They obviously don't go through treatment, but they go through the experience of having their loved one go through treatment, which can be very stressing. And a lot of patients rely very heavily on their caregivers. So can we kind of prepare them better and address their needs also, so that in the end, the dyad kind of is better off, the dyad being the caregiver and the loved one. So the summary of this is that we do think that coordinated care provides benefit to the patient, hopefully in terms of quality of life, also reduce hospitalization, but if you're a head and neck cancer survivor, you have complex physical and psychosocial needs really stemming from your treatment, and we need to better understand those. Patients now, because of HPV-related oropharyngeal cancer, are living longer, being cured of their treatment. And so we just need a better grasp of when these things are happening, what they happen with, who they happen to, so that we can do a better job of alleviating them or mitigating them through potentially, physical interventions like physical therapy or targeted interventions, or also potentially drug interventions to reduce things like fibrosis. MicroRNA, as I mentioned, are drug targetable, some of them. So there's a potential to not just take a kind of give you stretches and exercises, but to take a multi kind of modal approach to this. And science must drive clinical practice and public policy. So, the last part, I think, is really something that I don't know as a researcher I'm prepared to do, but I think the data that we have really helps us, the data that we get because patients come and they seek care from us can really begin to help us show the story of what head and neck cancer survivors experience, and then really work towards better policies related to care, and especially for patients who are kind of out of that, out of treatment, when they're less kind of closely monitored. What can we do? How can we serve you better? And then clinical practice really can still stimulate new areas of inquiry, and that is really pertinent to the needs of our patients. And some of the work that we do, we try to get patients involved in terms of as kind of stakeholders, because it really helps us when we're doing these interventions and trying to improve care, improve the models we have, to get your feedback on what we do. And so I want to leave it there so that we do have time. So we have about 15 minutes so to answer questions from the audience.
Thank you so much, Marcy, Dr. Johnson. This is a great presentation. And, as someone who's watched the survivorship clinic evolve over the last 6 years, it's really impressive to see how you've turned the data that you've collected from the patients that you've seen and incorporated it into your model, improving your model. It's a really nice process that you've created. So I think we're all very proud to be affiliated with the clinic and with you. So I have a couple of questions that our attendees have submitted throughout the presentation. So I'll pose them, and then you can decide between the two of you who ought to answer.
It'll be me. No, just kidding.
So the first question I have is, how do I know if my cancer was related to the HPV virus?
It's about 2007 or 2008. Almost all specimens are submitted for testing for HPV. And I can tell you 100% of specimens from the oral pharynx, remember that's the tongue base and the tonsil, are tested for HPV. So today it's routine. Nobody has to scratch their head or ask, it's just plain routine. And so we know, and as has been indicated, we know that people with HPV related cancer have a better prognosis, which means they're more likely to be cured. But it also means the stakes are higher in terms of survivorship, because if you're going to be cured, well, that means you have to live the rest of your life with some of these side effects that Marcy has elucidated. And we would like to do a better job of it.
Question related to specific symptoms. So if you are experiencing a late onset symptom like dysphagia, is it more difficult to treat successfully later on than it would be if you were experiencing it right after your treatment?
I'll let Dr. Johnson do this one too.
So this week, we have a symposium on survivorship. It's a day and a half. We have people coming from around the country and actually from Canada to be in our program. And one of the topics, of course, will be dysphagia. I think there's growing evidence and agreement that the sooner you treat people, the better. Okay? Because if you wait until they're really sick, it's very hard to undo it. So what's evolved here, as Marcy has eloquently discussed, is we start before you get treated if we have the opportunity to. I mean, we have to meet you. And we talk to people about swallowing. We talk to them about diet. We talk to them about how they can modify what they eat to maximize their health. And then we keep after them. And so some of our patients might wonder, why do I have to come back to survivorship every year? And, frankly, it's because that's our chance to renew your dedication and your commitment to doing the exercises that prevent or at least reduce the neck disability and reduce or prevent the swallowing problems. It's what it's all about. Because you don't have to go to a therapist every week for the next 20 years. You go to the therapist teaches you the things to do, and then we hope you'll do them on your own at home. And then we know that tends to be, you forget some of these things, you get tired of some of these things, maybe you're not sure you need to do it. And by coming back once a year, we get a chance to encourage you to be committed to your own good health.
Yeah, I think the other complication with when things happen later on is, you are aging. And so as we age, we tend to get additional things that happen. And so sometimes that can make it a little bit harder to really treat, because you may have underlying things like even neck surgery or worse, stroke, or those things can kind of compound how you swallow and your musculature. But that being said, even if I always try to tell people, when they're laid out and they're at home and they're not seeing us but once a year, even if there are little changes, because you'll know you're swallowing better. If there's little changes, like all of a sudden you've been swallowing this pill all the last 5 years, no problem, and now it's sticking. So we kind of coming in early when those symptoms start to change, always, I think, can help us try to slow any potential progression or worsening of your symptoms by giving you strategies to help protect your swallow. So when those small changes happen, I think that's the important part, is that you recognize them and that you get an evaluation.
Thank you. And we have kind of a related question that's specifically asking about physical therapy. So do you, in light of what you just said, do you recommend that patients undergo physical therapy immediately after treatment?
Yes.
And continue doing so for, the remainder of their years? Or, how do you see the progression of physical therapy in a survivor of head and neck cancer?
So I think it's important to and I don't know if you necessarily need a physical therapist to recognize that you need physical therapy. I think having a physical therapist do an eval helps, because there may be things that I'll miss. But I think, yes, after radiation, even if you're just deconditioned or surgery, it's good to get in contact with or get referred to a physical therapist to help with the myriad of symptoms that happen. So stiffness in the neck, trouble with the shoulders, trouble opening your mouth wide, tightness in your mouth, like even we've done some more physical therapy with intraoral work, pain in your neck. And even if you've had reconstruction, one of the things that we don't always think about but is really important is your donor site, whether that's your arm or your leg. So having physical therapy for those. Now I am recognized, and I hate to deal with them, but insurance companies also drive some of this. So you may be limited based on your insurance company. So doing physical therapy forever is probably not feasible for most people, but the physical therapists know that, and they recognize it, and they want to be able to empower you to be able to do these stretches and exercises so that you can maintain your function. And I always say, if things start to again change a little bit, we can always get you back to PT, and they can tailor it and give you a home program to do. So a lot of PT is really learning some of these things and doing them at home, which is hard because life, but it's that kind of, I always talk to people about, like, if you wanted to lose weight and keep your weight off, there was things you're going to do every day to kind of maintain that. And physical functioning is the same, just like your arm. If you want to maintain nice, strong arms, you're going to work at it every day. So it's finding that balance of being trained by being a physical therapist, being trained, and then, you know, working at home, identifying if things change so we can help.
So, you know, Marcy just introduced you a term that may not be familiar to everybody, and that term is deconditioning. So deconditioning is used by the healthcare profession to describe what happens when you stay in bed too long. You know, so I'm not kidding about this. When people get sick, they go to bed. When people have surgery, they end up in bed. And if you spend a lot of time in bed, what happens is your muscles begin to go away. They atrophy, you lose strength. And this is called deconditioning. So a deconditioning can affect your ability to ambulate, like to climb upstairs. It also can affect your ability to swallow. So deconditioning is your enemy. What I kid my young doctors about is my mother said, you need rest. And I'm here to tell you, rest is your enemy. You need exercise. You need to move. And this is important for everybody. So I'm not going to bicker about, yes, you need to sleep every night, and they say 7 hours. But for the other 16 hours a day, let's get out there and be active. It's really important for everybody.
And I did take a look at the slide. So I know there was a question about insurance. So typically insurance covers physical therapy for a set amount of points or point visits. Sometimes it's like 30, 35. And then insurances do typically charge you a copay. So your copay could be 25 to 50, it could be none. But yes, do you get a copay when you come to Survivorship and see our physical therapist? No. So if you were to come to Survivorship and you were to see me and Dr. Johnson and Jackie, who is our physical therapist, you get a copay for that visit, but you only get a copay for a visit to Johnson. One copay, unless you have a flexible fees, which is when they check your swallowing with the camera. Sometimes you'll get a second, but in general, it's one. The second one happens because of the state of Pennsylvania, and I can't get around it. I tried to make it as cheap as possible, so it's more feasible for patients. But you don't see. You don't get an appointment, you don't get a copay for Jackie or the physical therapy during that visit. If you were to go to Jackie, you would probably have a copay. And so I think it's very important to be your own advocate and say, I think it's more than reasonable to say, listen, I have a limited budget or I have a limited income and I can't go to physical therapy once a week. So what can I do? And I know that the physical therapist and I try to be very conscious of that. And so I think it's important so that we can give you things to do at home that may, and find out what can work in your specific situation.
So I have one other brief public service announcement. And that is, you know, Marcy has described in great detail how we have attempted to use you, our patients, to better understand what happens to people who are treated for head and neck cancer. And of course, the way we do that is through these series of questionnaires we call patient-reported outcome measures, sometimes by measuring, you know, the range of motion of your neck or the velocity of motion of your neck. And then what we do is we have tried to teach the other teams in medical centers across the country and around the world how we're using this and how it's helping people. And at the end of the day, what we're trying to do is change clinical practice. So the reality is that it's happening. What we are seeing is that other major medical centers who do head and neck oncologic treatment are starting to emulate us. And that's the best flattery we could have. This is what we want. In fact, we would like it if they would do it better than us so we can learn from them. Because at the end of the day, that's really what's the motive behind this, is to help more people and to be more effective in doing this help.
Thank you so much. I think you kind of covered a few of the questions in your reply. So I want to make sure that we get to a couple of more before we end at 1 o'clock. So I have a question here. Has the liquid biopsy technique advanced enough to be part of ongoing care or detection?
That's a no.
Okay.
Not in
yet.
the world of head and neck squamous cell carcinoma. I've been replaced as chairman, and the man who's replacing me is another head and neck cancer surgeon who's coming from Washington University in St. Louis. His interest is in the liquid biopsy. And so we can all get behind Dr. Zavalis and hope that this can move forward to where it can become an important clinical tool.
Thank you so much. I'll get to one more question, and then I know that there are a few questions here from individuals. I see a couple that are more personal in nature. I will send those to you, Dr. Nielsen and Dr. Johnson, following our talk today, and we can get the answers to our attendee who asked them. The final question that I would like to get to today: how do you go about getting patient buy-in for the survivorship program? Many patients seem to want to be visited with over. Many patients seem to want to be done with office visits, in-person office visits and appointments after treatment is over, and are reluctant to come to further visits. How do you encourage people to come into the clinic and maintain their relationship with the clinic?
So I would say my winning personality now. So I think one of the things that we try to do is empower patients. So, and we are flexible. So when you come in, would I love it if you came in at a set time and we saw you like 3 months post-treatment? Yes, but I think part of it is trying to make it as easy as possible on the patients, and also highlight, that our goal is not to see you all the time in Oakland. I don't want everybody coming into Oakland all the time if they don't have to, but to really help empower you to know what to look for. And I think we also can track over time. So the benefit of survivorship is we track a lot of things that are related to quality of life, and we can see changes over time. And so it helps us kind of provide this network so that we can minimize some of these things that happen, whether they're symptoms or admissions. So I think it's highlighting the benefits to survivorship while recognizing we do try to minimize the burden to patients, and that patients do, if in between visits, if they have trouble, they're more than happy to call or text, and call or email, and we answer. We try to make it as easy as possible. So if you have a question or something that arises, and you've been to survivorship, usually we know your treatment, we know your history, we know your trajectory, and we can try to do some of that coordination without getting you to Oakland if possible. The other thing that we do try to do is we try to, if you need things like physical therapy or speech language pathology, we do try to get it as close to your house as possible. So I think that's helpful for patients, and I think that helps them realize that we want this to be convenient. We do have speech language pathologists and physical therapists in here in Oakland, but it's not realistic for people coming from Erie. And so we do have those networks, and we built those networks. And I do think that helps patients see that we've worked really hard to try to make this convenient to them and make it accessible to them. And that we really are interested in how you function and improving your quality of life over the long term.
And, we do look forward to kind of the evolution of technology. Marcy and I have discussed many times how we could use modern technology to communicate with people and enhance their recovery, how we could remind them to do their exercises, to remind them about what they might do to improve their nutrition and their diet. And I think those are opportunities for the future. We're absolutely committed to continued change. There will be change. And if some of you online have suggestions, let's hear them. We would like to know what you're thinking.
Well, I want to thank you both for taking the time today to give this presentation, to answer the questions from our guests online. This was really a great webinar, and I learned a lot, and I'm very excited to see what the survivorship program comes up with next. I know we'll probably do another one of these webinars, maybe, down the road, just to see how everything evolves. So with that, I think we'll go ahead and end. I think it's right about 1 o'clock. I know there are a few questions that we didn't get around to answering. I will make sure to send those to our speakers, and they can offer their insight and hopefully provide some help. And I'd like to thank everyone on the webinar today for spending your lunch hour with us. So thank you, everyone. We'll see you at the next webinar, and have a great Wednesday. Bye-bye.